Everyone, I am Ninan Jacob and I will be presenting the third talk on choroidal osteoma today, but I will be concentrating more on its complication, that is CNVM. So it's a benign ossifying tumor where a mature cancellous bone replaces the choroid. Its etiology is elusive and there is no known ocular or systemic risk factor. And this choroidal osteoma can complicate and form a CNVM, which ultimately leads to visual loss. The purpose of our study was to analyze the clinical characteristics and follow-up of eyes with CNVM complicating choroidal osteoma. It was a retrospective multicentric study done with the help of electronic medical records conducted from 2012 to 2024. We included patients with diagnosis of choroidal osteoma and CNVM, and we included patients with age more than 18 years, no history of ocular surgery or systemic comorbidities. We collected demographic data, clinical findings, imaging details, that is fundus photo, autofluorescence, FFA, ICGA, OCT and OCT angiography, its treatment done, and the follow-up were also documented. So in total, we had 73 patients or 92 eyes with choroidal osteoma, which included 37 males and 36 females. And out of that, 41 patients or 44 eyes had CNVM, that is 17 males and 24 females. In terms of the location of the choroidal osteoma, majority of the patients, that is 72 of the lesions, were involving the macula. And nearly 12% involved the peripapillary area, and the rest 3% were in the periphery of the retina. When we compared the age of presentation in eyes with CNVM and without CNVM, the eyes with CNVM presented earlier at an age of 28 years compared to those without CNVM with a mean age of 34 years, but this was not statistically significant. Similarly, when we compared the visual acuity at presentation with eyes with and without CNVM, though the eyes with CNVM had a poorer visual acuity of 0.4 logMAR units, it was not statistically significant. We also conducted multimodal imaging analysis in eyes with choroidal neovascular membrane. On FFA, we could note an early hyperfluorescence with late leakage, and the tumor tissue was also staining with the dye, whereas on ICGA, a well-defined neovascular net with minimal leakage is noted. On OCT, subretinal hyperreflective material, SRF, intraretinal fluid, RP and outer retinal loss were noted, and on OCT angiography, minimal to patchy areas of choricapillary loss and neovascular network was noted. So this is a slide describing the multimodal imaging findings. In image A, we can see a choroidal osteoma seen as a hypopigmented yellowish lesion, approximately 5 disc diameters in size along the infratemporal arcade, and where the arrow points, we can see a subtle subretinal hemorrhage. In this FFA frame, we can see where the arrow points an area of hyperfluorescence and leakage surrounded by an area of hypofluorescence corresponds to the subretinal hemorrhage, and below that we can see the area of staining of the tumor. In this ICJ frame, similarly, this arrow points to the area of CNVM network, and surrounding that we can see areas of choricapillary loss, and this area we can see both the intratumoral vessels and the pushed out outer choroidal vessels. OCT angiography also shows this well-defined neovascular network and this area of choricapillary loss and the deep choroidal vessels. On OCT, the subretinal hyperreflective material can be seen along with the presence of subretinal fluid, intraretinal fluid, and intraretinal fluid. When we analyze the factors affecting CNVM at baseline, we notice that the presence of deossification, presence of baseline RP atrophy, and its location being foveal or perifoveal increases the risk of CNVM formation. In total, among all the eyes with CNVM, 12 eyes had scarred CNVM, and all the other eyes with active CNVM were treated with anti-VEGF injection, except one which was treated with focal laser, but it was away from the macula. And all the eyes received a mean of 4.1 injections throughout the treatment course. And at a mean follow-up of nearly 15 months, CNVM regressed in 56% of the eyes, and improved or stable vision was noted in 12 eyes, or nearly 30%. And during this period, no eyes showed any lateral growth or decalcification. So to conclude, although choroidal osteoma complicating to CNVM is rare, the risk of CNVM formation is nearly 47%, and multimodal imaging helps us in getting an accurate diagnosis of CNVM. The risk factors for CNVM formation are deossification, RP atrophy, and foveal location of the tumor. And post-treatment with anti-VEGF injections, CNVM shows stabilization, shows CNVM shows regression and stabilization of vision in nearly 30% of eyes. Thank you.
It's a sad story actually. If you detect late, generally
Yes.
there's a scarring. So most of the time, probably we may diagnose. You want to say something? What may be the cause for a? What are the causes for late?
I'm sorry, sir.
The late presentation or late diagnosis? What is the in your experience? Because
Late presentation. Maybe if the CN choroidal osteum is located in the subfoveal area, because of the decalcification, still the patient may have a loss of vision. So we may not, and because and we have seen in our series that sometimes the tumor grows into the subretinal space. So it is kind of difficult to distinguish a CNVM from a choroidal osteoma breaking through into the subretinal space. That might be one reason where we are diagnosing the CNVM late.
moment is developed CNVM, it's very difficult to give the restoration. Okay, thank you.